perhaps is no total model of addiction or substance misuse or whatever you want to call it that is going to please everyone. But one model that is there, sometimes explicitly, sometimes implicitly, is this public health model. And I'm going to link that to something nothing to do with addiction, that public health doctors traditionally have thought about this idea of agent, host, and environment. And that is something that emerged in the 19th century before we had all of the developments in microbiology. The agent referred to the specific carrier or the vector for the disease. The host refers to the individual person who might get the disease, and people have varying susceptibility to different conditions. And then the environment referred to the physical or the socioeconomic environment, the circumstances within which the hosts lived. We are accustomed to seeing the life expectancy in most developed countries has improved very, very radically. People live much longer, people are healthier. Arguably, the advances in life expectancy and in health generally are just as attributable to environmental measures as they are to developments in clinical medicine or surgery. So that going back into the 19th century, it was things like the provision of clean water, sewage systems, food hygiene, housing standards, things like that, rather than new drugs and new forms of surgery. So that is a kind of an old public health model. In 1984, an American psychiatrist, Norman Zinberg, wrote a book called Drug Set and Setting, which in many ways reflects that public health model. And this model looks specifically at psychoactive drug use, and it mirrors that public health kind of triangle of agent, host, and environment. The drug, here we're focusing on the drug itself, the properties of the drug, how addictive it is, its toxicity and so on, its capacity to affect the person that uses it. Set refers to individual factors. The individual user's physical, psychological characteristics, strengths, vulnerabilities, and the setting then looks at the importance of environmental factors, whether these are familial, socioeconomic, political, whatever. And the application of this model, it suggests that if we're to really understand drug use and drug-related problems, we probably should consistently use that three-pronged approach. That policies or strategies that base themselves on just one of those factors, we would describe it as reductionist, it's unhelpful. It's trying to look at something that is very complex and explain it in terms of just one attribute, one factor in a very complicated multifactorial situation. And the difficulty is that application of this model isn't always popular, politically acceptable. If you were to focus solely, say, on the drug issue, you would commit yourself to the war on drugs. We're going to solve the drug problem by getting rid of drugs. Well, we're probably not ever going to get rid of drugs. The notion of set, we're just going to focus on the individual person who's become addicted and treat them. But very often the setting one is the one that is complicated, and people don't like to think of the wider environment, the political context, socioeconomic inequality or whatever it is, or the fact that we have allowed the drinks industry to become such an influential player in our society. I'm going to talk about application of the model in Ireland. We're going to look at the heroin thing. The heroin hit Ireland almost sort of out of the blue, about 1979, 1980. And we had the first experience of heroin in Dublin, and we had the sort of shock of seeing that the first style of drug use was injecting drug use. Young people in Dublin who had never used drugs previously, their first experience of using drugs was by injecting heroin. And the early response, maybe predictably, was very much focused on the drug element. The notion that we're going to use the criminal justice system, we're going to whack this and we're going to get rid of it. So you can see that the legislation, the Misuse of Drugs Act, which is the basic basic drug legislation in this country, had been enacted in 1977. In 1984, that was amended, and one of the main things they did was to introduce much tougher penalties, like, for instance, the introduction of life imprisonment, life sentences for people convicted of drug dealing. Generally, having a kind of a tough criminal justice system, we are going to solve the problem this way. And we know, most people know anyway, that, say, the United States has had this for a long time. They ended up with very enormous numbers of people being sent into prison, which didn't appear to help very much. Treatment and rehabilitation responses initially in Ireland were based on the individual. The individuals, the heroin addicts, whatever they were seen as, they were the defective individuals. The notion was you kind of pick them from where they are, you plonk them down into a treatment service. Very often we were aiming towards trying to have residential services, and they're going to be fixed. They're going to be taken out of their own environment, their own neighbourhood, their own family, whatever, dropped into a treatment centre, and then someone will get to work on them, and would, like, you leave your car into a garage, and you come back later on and pick it up, and it's okay. So at that time, that first set of responses, we were focusing on getting drug addicts drug-free and keeping them drug-free. We did move, I suppose, relatively quickly in some ways towards looking at the setting issues in Irish drug policy. The Medical Social Research Board, which then changed into the Health Research Board, had done epidemiological research from the beginning. And what they showed was that serious drug problems were not randomly distributed across geography and across geographic boundaries and socioeconomic boundaries, but that they were largely concentrated in areas of social deprivation. That you could pick the areas that were going to have heroin problems, and those areas unfortunately did have them. There was a lot of reluctance initially at political level to accept that serious drug problems were almost like another face of poverty. And for a long time, the educational activities were of the, I'd call them the Nancy Reagan just say no variety. So there were all kinds of people, kids who were not really at risk of developing heroin problems, being told about the evils of drugs. Where the kids in the areas who are most at risk weren't necessarily having any preventive work done that had any real prospect of making a difference. The most obvious and dramatic change occurred in Irish drug services when HIV/AIDS came along a few years later, and when it became clear that the sharing of injecting equipment was one of the main ways in which this new virus was going to be carried into the drug using community first, and then through sexual contact possibly into the wider community. So the psychiatric services, which had always been a bit iffy anyway about drug problems, were largely displaced, and public health people got involved because the big issue now is HIV/AIDS, and services moved towards more of a focus on setting, recognizing we need to concentrate scarce resources, target them at areas where there is high risk, areas of great poverty, and generally move towards more pragmatism in how we deal with things. And the notion of the ideal of getting everyone drug-free and keep them drug-free may not be realistic. In 1996, we had a report, and the name of the report I put there, it trips off the tongue lightly, as you can see, the first report of the Ministerial Task Force on Measures to Reduce the Demand for Drugs. Not surprisingly, a lot of people referred to it as the Rabbit Report because it was chaired by Pat Rabbit, and it's probably easier to say the Rabbit Report. This was an unusually explicit, in-your-face public health report, and it said drug use is, or heroin, the drug problem mainly at that time is a heroin problem, and it is in areas of poverty. And that was a hugely important report. The Eastern Health Board in Dublin had previously been trying to develop some services, like needle exchange started in 1989, and there had been some harm reduction agencies started, the Anna Liffey Drug Project in 1982 and Merchants Quay Project in 1989. But Rabbit was very explicit in acknowledging heroin is concentrated in areas of urban poverty, and that preventive and treatment resources should be targeted at these identifiable areas, and the main mechanism that was suggested was through local drugs task forces. mechanism whereby local people, community representatives can collaborate with representatives from statutory agencies and others at local level, can say what the problem is and see what might be a good either preventive or response to those problems. And Rabbit was also clear, very emphatic about the need to expand the provision of methadone maintenance, and that led in 2 years later to the introduction in 1998 of the methadone protocol, which was a mechanism whereby GPs will be licensed to prescribe methadone.